So after this, we'll split into ALS and BLS tracks. They're not always in the same room. So depending on which one we're live streaming, it's going to be here. So on your brochure, it'll tell you like room 200 is here, 206 is back there, kind of go around the corner. And then if you're in the OJ group, you're going to go around the corner, it'll be the smaller classroom on the right, and if you're the other classroom, will be on the left. So hopefully it's clear tonight. We'll be able to come direction. So yeah, so the ones that are on Go webinar will be in here. So that's why we're moving around and it gets this up. All right, that's all I have here.
At least you got a response. You're welcome. Thank you. Everybody's slowly trickling in. Good morning, everyone online. Welcome. Happy Sunday. All right, we'll give everybody a couple more seconds to find their seats. All right. While I drink my chai. All right. Well, good morning, everybody. Happy Sunday. Happy last day of Eastern Oregon EMS Conference 2025. So excited to be here. You want the lights off? No, not at all.
Do you guys want the lights on or off?
Are you going to fall asleep? No, you promise? Have you seen the like, oh, that's too much. This is an EMS conference. What happens at nighttime? All right, well, good morning, everybody. Welcome to those online. I think I've given you a couple minutes to sneak in. Today we're gonna go over the Oregon Health Authority EMS Program 2025 update. My name's Stella Roush Scott, but I just go by Stella Scott. I have been at the program for about 13 years now. Previously, I worked for a private EMS agency on transporting, and my lovely cohort here was actually my partner in some calls. Yeah, not being recorded. You don't need that. And I worked for a volunteer firefighter, or as a volunteer firefighter for many years. So just a little bit of my background and who I am. My current role is 0.05 FTE is duties as followed. That's my job, because apparently what I used to do and was hired for didn't happen. I am seeing where this works. Let's see. It was working earlier. I think I just have to click on it real quick. There we go. All right. I oversee the boards and committees for the state. We'll be going over what that actually is because it changed as of January 1st. I go around and I do the regional ATABs, which those are the groups that kind of oversee and decide on what you're going to do in your region for trauma calls. I also am the cardiac arrest registry to enhance survival. CARES registrar for Oregon. So I oversee all of the cardiac arrest pre-hospital stuff in the state. And I also manage the stroke registry for the state. So just a couple jobs. Today, we're going to go over 2024, our highlights. This is what we are building on. And so that's why we're going to focus on 2024 a little bit, because what happened in 2024 is really what's going to be changing in Oregon and for you all in 2025 as we move forward. I also have my lovely Rebecca Long. She is a professional standards unit lead for our program. PSU, we love them and we're not terrified of them. They oversee all of the renewals, licensing, backgrounds, all of that stuff. So she is here for Q&A as well if you guys have any questions about, renewals that are coming up. So, and anything else. Between the two of us, we should be able to answer something. And for those online, you can go ahead and put your questions in the chat, and we'll go, when we get to Q&A, we will answer those. So please feel free to enter into the chat. All right, so 2024, it was a big year for us, and I mean us as in EMS in general. EMS modernization, have any of you heard about it? Do you know anything about it? Oh, wow, this is amazing, this is all new. Okay, so Rep. Graber, who is one of our representatives, proposed EMS modernization, House Bill 4081. It's like, oh my goodness, because we have another one. This bill went into effect January 1st. It was signed in July of last year. This bill is taking our office that has been and our program that has been kind of just sitting there for many years. And we're going to move to the future. So it's really exciting. There is a lot of work. There's a lot of work in the background, but we're going to go over how it's going to affect you all and what different things in this bill are going to be kind of looking at everything. I'm going to go through. So the different requirements in the bill do build on each other. When we're going through this, it's not that one thing, like it's a timeline. It's everything's happening at once, but then also not happening at once. So it's gonna be super fun. You can get your phones out. There are some QR codes if you want to access them on this presentation. They're also gonna go ahead and send this out afterwards, I think, is what they've told me. So we have the trauma system. We all know the trauma system, right? I'm hoping I see a hand up there. Anybody activated a trauma in the field? Okay. Thank goodness. So we already have a time-sensitive emergency plan for traumas. We have a trauma system in the state. Everybody knows what they're supposed to be doing. Hopefully, we have the trauma bands. We have dispatch that knows what they're supposed to do with trauma. We have all of the hospitals that have gone through and done the certification and the requirements to become a trauma hospital. We have 4 levels in our state. Level 1, those 2 reside in Portland across the river. And then we have 2s, 3s, and 4s. What this bill does is we're going to take what the trauma system is, and we are going to also make a cardiac system and a stroke system. So similar to what trauma does, you will have hospitals that are designated, have gone through their classifications and have met all the requirements and guidelines. There are going to be these hospitals in each region. We talk about ATAB, Area Trauma Advisory Boards, and those are the regions that we create. It's where your transfer patterns are. It's where you will most likely take your trauma patients to. They oversee dispatch, they oversee QI. There's like how patients are going to be transferred. So those are the trauma regions. They are going to be called REMSABs, Regional EMS Advisory Boards, and we'll go over that in a little bit. Those start next year in 2026. So I will reference ATAB as REMSAB as we talk about stroke and cardiac. Okay. Who's seen the updated? Yes, I got more hands without like waiting a minute. Great. So October 15th, 2024, we updated what the triage guidelines in the field for trauma are. We will have similar ones created for stroke, cardiac, and different types of cardiac. But red criteria is high risk for serious injuries, and yellow is moderate. Looks a little bit different of how you go through the plans. And this is all online as well. Hopefully you have had access to it and have seen it. Your medical director has brought it to you. If not, talk to your medical director or your EMS chief or your manager. Yeah, so these are boards. These are what I'm over now. It looked a lot different before. All of our boards and committees were siloed. Everybody did their own individual thing. Everything was kind of created throughout, and stroke focused on stroke, trauma focused on trauma, EMS focused on everything and tried to work with everyone. We had a EMS advisory board or an EMS board committee. We had the state trauma advisory board. We had the stroke care committee. We had 7 ATABs, the area trauma advisory boards. And we had EMS for children. We scrubbed it all. We said, this is not working anymore. People were bouncing between the two. No, there was no like fit goal that was all designated into one. Everybody kind of had their own system going on. So starting in 2025, actually February 14th during the snowstorm, it was awesome. We had our first EMS advisory board meeting. They're going to be the leads. We have EMS providers. We have rural fire that don't transport but do respond to calls. We have private agencies. We have EMS physicians. We have or medical directors. We have the fire union representative on it. There is a spot for a third-party payer. We have nurses on the board. We have ED physicians. We have a group of people that we all work with and work with us, and they're going to be the ones who are going to make the final recommendation to our office and say, this is what we all think is the best way to move forward with these systems. The board and committee structure, as you see here, we have time-sensitive medical emergencies. We're breaking those out because when you get to the bigger hospitals, they have their own little core cohorts that fit into their own specialties. So trauma does only trauma, stroke does only stroke, cardiac does only cardiac. So these are the people that are going to say, this is how we want this system to work. They're going to take it and send it to the time-sensitive medical emergency committee and say, this is our recommendation. This is what we think is going to work. These are the workhorses that like know what they want, know what's going to work, and it's filled with EMS providers, stroke nurses, stroke people that fit into each category, but you guys are actually sitting in the room helping make those decisions. So they'll make those recommendations to the time-sensitive committee. The committee will send it on to the EMS advisory board. And then we have EMS for children that focus on pediatric care. And we have the EMS advisory committee. This is very similar to our EMS committee. They do have a licensure and discipline subcommittee. These are our professional standards, sometimes have cases that are not black and white, and they would prefer to have peers and medical directors sit on this. So EMS providers of all ranges, EMTs, EMTs, paramedics, and EMRs, like anybody that is a provider that is in this committee can sit on this committee, be chosen to sit on this committee. So it's your peers that are looking at this case and saying, this is our recommendation. So that's what that licensure and discipline subcommittee is. Behavioral health, we're going to put it to the side. In the bill, they thought we could solve everything in behavioral health. We know that's not true. So we're putting that on hold right now. And then our REMSABs are going to start in 2026. And in 2027, as of right now, because there's actually a bill right now that's affecting this, there's long-term care and senior care emergency medical services advisory committee. What are we going to do when we go to those care facilities? All right. Here we go. Part of this bill also said we need all of our data systems to talk to each other. Everyone has to have a data system. Stroke has to have a data system. Trauma has to have a data system. Cardiac has to have a data system. But we want them all to talk to each other. And then your charts go into our EMS or MSIS, Oregon Registry for EMS Information Systems. When we take all of that data, we, in our program, get asked to do a lot of things. We have dashboards where we're looking at, issues that might be happening that maybe we can work on, and we'll look at that in just a moment because there's actually a project we're working on. Legislative reports. In our bills, it does say that we have to give a biannual report to the legislation on how we're doing. So we take all of that data, we'll show stuff like how awesome we are, and we, I mean you all, how great we're doing, and what our recommendations are for improving the systems, what we need. money to help build positions, to help move it forward, money for the regions, things like that. And then we'll look at regional QA and QI. Part of the ATAB, which is going to be REMSAB, is part of the work that they do is they look at the data in their system and how they can improve care. Ground level falls, what's that looking like? Transfer, how long does it take to transfer a patient from one hospital to the other? Intubations, death in the fields, things like that. But we help support that in the regional QA, QI stuff. So that's where your data is going. But we can only give good data if we get good data from you guys. So stroke assessments. If you're in your, when you're writing your chart in the drop-down box, there's probably, I think we've counted, there's about 100 and something of these in there. This is just a snapshot of what it looks like right now. Somehow there have been a lot of stroke assessment options, our stroke scales, that have been created and put into our OR-MSIS. When you write your EPCR, when you're writing your chart and you drop it down, there are many options, and they might be the same thing, they may not, but we're not quite sure because some of them have 0, some of them have 33,000. So when we're looking at our charting and how we're doing this, we have to have good data in order to actually really look at what we're doing. This is a dashboard that was created from our stroke system, and this is what we're looking at on stroke scales. So this is actually an agency that let us use theirs. This is one agency. And you can see in here the stroke scale type that they're using. Not reported. We know this agency is not doing this. What's happening is they're writing it into their reports. They're writing it in there instead of documenting it. So when we pull the data, we're not pulling those little reports and reading through every single one that's coming through in the state. We're looking at it and saying, oh my goodness, what is happening? Obviously, some education needs to happen. And actually, we're working on getting this education out. This was the final collaboration between the Stroke Care Committee and our EMS committee, working on getting just a reminder and recommendations and how to do this. But a reminder that when you're writing your charts, it helps, and why we're collecting this data and why we're having you guys do it is because we have to figure out how to create a stroke system in the state. And when we have somewhere where it's saying it's not reported 17,000 times, gives us a little pause for a moment saying, is our data good? What else? There we go, CARES. This is my baby. And for those of you that are joining us for the Resuscitation Academy, we're gonna go over this a little bit more. But CARES is our cardiac arrest registry. This is the first registry we had for pre-hospital EMS charting ever. So it's really special to our program and to our state because this is where it started, even before we had our EMS information system. So started a long time ago. There are data points that we collect from your charts. Each agency has a person that is my contact in that registry. And this is for the transporting agencies only, or who transport the patient. So you may be a secondary fire agency that does have the option to transport a patient with an ambulance, and sometimes that happens. So just saying, this is not every single cardiac arrest, and we have multiples, it's one patient. But all of the information in here is collected and then put into the CARES registry. We look at many options. I have counties that work together and have like 5 or 6 different fire agencies that are transport agencies as well as private agencies. And we all work together with the medical directors and say, how can we improve? Some of my counties work with their dispatch and their law enforcement and look at law enforcement coming up. And we'll talk about that in a second. But all your information that's going into your chart is then put into this. So if you don't chart it, it doesn't happen, right? No. If you don't chart it, We don't know what we can improve. This is for 2023 with the bystander CPR. And we're looking at community outreach here. This is what's showing us, like, how can we work with our communities with bystander CPR? Out of our bystander was started on 2,722 people last year, or not last year, but the year before. So we're looking at finalized data. 55.9%, that's fantastic. We're very excited about that. And then there was 490 AEDs deployed for each call. So 490 people got an AED from a bystander. This is not first responders coming on scene. We are tracking as we are looking at our staffing and agencies getting smaller, volunteers we don't have as many. We know that there are issues. We are very well aware of that. We know agencies are shutting down because they no longer have volunteers and are volunteer-based only. Mutual aid is happening, but what is happening over the last I'd say about 7 to 8 years, law enforcement is starting to show up because they're a first responder. They are in smaller vehicles. They're already out on the road. They're being deployed to the cardiac arrests to start CPR. We know that every minute that a person loses or an intervention is not taken, CPR, something like that, they lose a 10% chance of survival. So every minute that we don't have somebody on scene, if a bystander can't do CPR, they're not doing it accurately-ish, we know that that person has a less chance to survive. So we're sending out law enforcement. We actually have a program going on where our rural and frontier law enforcement agencies on patrol are getting AEDs in their vehicles through a grant from our CARES program. So we're trying to put AEDs in more vehicles because we know they're showing up. That is a big change from many years ago when law enforcement didn't show up at all, but we know they're the ones that can most likely get there. This is our infographic. So this is for 2023. This is kind of an oversight of all of it. And what the CARES registry does, just so we can finalize this, is that then I have contacts in hospitals that if your patient's taken to that hospital will complete the chart of what happened to that patient. So we have outcomes that come out from this, and we can look at how our resuscitation for sudden cardiac arrest, how we can improve. There's lots of science that goes into it, but we have to have good data in order to get stuff like this. So with that, we have 2025. It's going to be a huge year this year. We already have launched our boards, and those boards are going to be the ones that are making those decisions. The committees are going to be making the decisions and helping us create these time-sensitive emergency systems of care. May is when we are going to have about 70 to 80 new committee members, and you all can actually be on it, and we'll talk about that in a moment. It's legislation session right now. So 4081 was the first bill of 3 to change our system. Right care, right place, right time. This is their little logo. Rep Graber presented a second bill a couple weeks ago. Bills may come out with lots of stuff going on in them. By the end, it could have completely changed. Things can be removed, things can be added. So the bill currently, and what we're going to talk about, may not happen, but these are goals eventually. So House Bill 3572 talks about our program having to make a strategic plan, a 10-year strategic plan of what we're going to do for 10 years. Similar to what the fire mobilization plans are for the state when there's a disaster, we're going to talk about creating an EMS mobilization plan, moving ambulances around the state to help support communities that maybe in a disaster and may need further support, but this allows the governor to move ambulances around and those agencies getting paid for it from disaster funds. Directs our program to provide loan repayment subsidies to licensed EMS providers. These would be grants for providers to be able to go to school and get reimbursed by our program through grants for their schooling. And there is funding requested for REMSAB, regional boards, to give them funding to help support EMS or emergency medical services within their region. EMS Compact, who's heard of EMS Compact? Maybe, no? Ah, good job, thank you. Thanks for that big hand up there. Oh, there's a little hand. EMS Compact is a national program where you have a license in one state. If you're going over to another state for, say, fire, you don't have to get a license at that state. You can use your license in this state to go to another one who all are a part of this EMS Compact. Similar, those providers can come here to provide care for fire, things like that. If they're moving, they have to get a license in our state, but it allows the lines to kind of disappear while we're providing services and helping each other out. And then what else? So REMSAB is already happening. There are already states around the nation that are all a part of it, and they have to connect, I think, is what my initial understanding of it is. Oregon is not a part of it. This bill that's proposed right now is making it a requirement that we're a part of it. So if this bill goes through and that's still in it, it would happen. So again, bills change. Yes. Yep. Eastern Idaho, Western Idaho. Yeah. We're presenting to you guys. We go to the ATAB meetings, we talk with the ATABs, we go to the hospitals, we talk to the hospitals, we go to the agencies. Our program, we are small but mighty, and we try and get this information out. And Rep. Graber has representatives from around the entire state in all different locations that are representing. So the Fire Chiefs Association, the Volunteer Firefighting Association, I know they've talked to them as well. There is ways to communicate, and we try our best. But if you're not active in it as well, and your agencies aren't active and you're not responsive, we also can't be reading your minds. So there are opportunities to help, but you also have to be a part of moving forward with it. We try our best to get to everyone. Our ATAB committees, there is a lot of work going in there and not a lot of fire EMS representation there. Does that answer your question? Maybe. Okay. When was the last time you went? I'm not aging you here, but when was the last time you went? Okay.
Yeah, I'm just curious. It sounds like.
Yeah, and
So those are the kinds of things that make us pause.
Makes me pause too. Yes. That is a great question. Let's get back to it at Q&A. Okay, well, people online can't hear, so, okay. Yeah, we'll answer, we're tracking your question. Thank you for that. There's a lot. Also, there is a part of this bill they put in there for EMS license reimbursement, where we would look at subsidize the cost for your license. So that is another part of it. Again, this is the first part of the bill, and it changes. as we go through legislation session. This is what has been proposed. Things can be added, things can be changed. All right. Yes.
Can I ask a question? If I were to interpret what you were saying about the House bill, all that stuff coming through, I believe what I was hearing is the more action that we as EMS providers want to see on House bills or Senate bills, we need to be contacting our representatives to let them know how we feel about them.
I love how you put that. Yes, contact, if you want this to pass, if you are passionate about something, if you think something's going to work for you guys, that's where your representatives, your government representatives come and play. You can contact their offices. I don't know who they are for you, so look it up online. It's all there. Want to get involved? Do you guys want to have a voice in this? This QR code is to our application form. There's also going to be, is it not coming up? Okay. It's also, so apparently it's not working right now. I apologize, but, oh, it does. Okay. Sorry. I was looking at one person. She needs to QR code it again. Scan it again. It comes up to the application form. We are looking for EMS providers, for you guys in the field to help us build this. What's going to happen in ATAB 9, your guys' region, what's going to happen in rural and frontier communities, you get to have a voice and make those changes. So we have plenty of position for EMS providers, firefighters, public agencies, private agencies, law enforcement in the back. There are positions and we are trying to fill them. Our first committee meetings and first trying to create all of this starts in May. Community paramedicine, my other baby on the other side, CARES and MIH. There are 2 bills out for MIH, and as much involvement, it is not at OHA. We are not allowed to. We are allowed to give feedback on them. We are not allowed to give our personal opinion about it, but there are 2 bills to further enhance MIH, mobile integrated health, community paramedicine for the state. What about it? What about community paramedicine? I think in general, yeah. Want to get involved? QR code. We're also sending this PowerPoint presentation out, so if you don't get it today, you forget about it, I'll be you'll have opportunity to access it. This is how many providers we license and have licensed in our state. 12,000 of you. This is all across the board, and you see a breakout of it, mainly paramedics and EMTs, some EMRs, some AMTs and EMTIs, which is a unique license for us since that license no longer is national. The question that comes up often when they're seeing this number, when we presented it, is where are they? And we don't know. So coming this renewal cycle for all of you, there are going to be a handful of questions of how you use your license. Your answers do not affect your license in any way, your renewal license, those answers that you give. So we are just looking at how the licenses are being used. For example, both of us are licensed, we both have our licenses, and neither one of us work in the field. So -2, so 940. And it continues and continues. We have a lot of different opportunities for EMS providers in our state. Some are retired, we know that, and they still keep their license. Some work in the hospitals, admin, you know, are you mainly on the road, or are you administration? Are you leadership? How does your license, like, what are you doing with your license? And if you're using it in the field, because we see 12,942 providers. And when people are saying that they don't have providers and hiring is not happening, we can't answer why. So if we don't know what the problem is, or we know what the problem is, but if we don't know where you guys are at, we can't answer, and we can't work on moving forward and creating systems and helping support agencies and you all in the field. Why you're all here. April 1st, renewal. It starts. Avoid the late fee, it's $40. June 30th. If you live out of state, if you've been out of state for a consecutive of 60 days, if you do not have a current Oregon Department license, your license is for another state. No, there's no questions.
Lots of questions.
Oh, there's awesome,
They
but we'll get
can't-
them.
They can't hear the discussion.
Oh, okay, perfect. Thank you for tracking that. I will repeat in the microphone. Sorry for those online. Yep, will do. Okay. You will get fingerprinted. You are required to be fingerprinted for any of those things. Do not let it go. Get it done, because if you get it in at a later time, you may lose your license for a few days, because it's going to take our office longer to process all of that. So do not delay. Those are for no current license. If you've traveled out of the state, been out of the state for 60 consecutive days, if you live out of the state and you have an Oregon license. Yeah.
That mean if you take a 2-month vacation, you need to notify you that.
Oh, I wouldn't say that in here. Did you notice I brought a professional standard unit lead? I told you she's our friend. We do not lie. If you are out for 60 consecutive days, doesn't matter if it's a vacation or not. Are there exceptions for military? Is the question. I will answer that at the end. I'm only repeating for the people online. I will answer that question in a moment, because we're almost done. We just have a few reminders. If you want to avoid the late fee, avoid by June 1st. Even though you have till June 30th, if you get it in before June 1st, your renewal application, it will be, unless you have been asked to fingerprint, and that goes into your junk mail. Okay. Sorry, they clicked on the. These are printed out. Some of you have already grabbed them, but if you are not sure, these are our Appendix 1. This is all of the requirements for a renewal, but these are printed and on our table out in the hallway if you would like to get one. Mike Lee, probably if this is not your first renewal, you've probably seen it. Yeah. All right. We're almost done, and then we're going to do QA. So it's probably about right on time. So let's see. Okay. Finally, if you want to know what's going on in our office, updates like these, opportunities to serve, classes, we do have regular, EMS for Children's has regular pediatric classes that you get CE for that they provide online each month. So things like that. This is what we call our quarter report, where we give updates on projects that are happening, lots of things, meetings that are coming up, education changes at the schools, things like that. It's all here. This link never changes, but the report does. So we update this every quarter, and we send this out to a lot of people, but we're realizing that you all don't get it unless you're in leadership, and people don't know about it. So here's the link. And with that, questions. And there's lots of them, but we're going to start with the first one in the back, which the question was, if you're in a military deployment, will you get fingerprinted? We're going to trade this back and forth because I have questions too.
Okay, perfect. Thanks for the question. No, upload a copy of your DD-214 and you're fine. I trust the military is keeping an eye on you. Other questions? You have questions about compact? Let's go back to that one. Yeah, so for at home, the question was, if the EMS compact again gets adopted in this bill, like we said, this bill dropped a couple weeks ago. It's 40 pages. This is where it kind of goes on the chopping block and things get taken out for it to pass. So they get through, like Dacia Graber works for TVFNR. She's an EMS provider and firefighter. She's in this, she knows. She's a great rep. She's pushing this forward in Oregon. But it comes with give and take. So for the whole bill to pass, sometimes things get removed. Again, we have no stake in it. It's just, we're the vessel to kind of give you guys the information. It's the public and the input from you guys. If there's testimony and feedback, that's the direct, it pushes the bill. So to answer your question, when we become a compact state, if we do, I think there's like 22 states in the compact right now. To give you guys some history, it's kind of like your driver's license. You can drive into Washington and use your driver's license there, but if you reside there and you want to live there, you need to get a Washington driver's license. We're going to do the same thing with EM. They do it now in those compact states. Oregon is not currently a compact state. So if you come here, you have to get licensure to operate here. It does require National Registry EMT licensure, but as the home state, everybody is required to have a national registry when they initially get licensed. So even if you don't still have your national, you can be part of the compact. It was the standard when you were initially licensed, which is part of that. So and then there's like home state and practicing state laws and rules that come into play if people do transfer across lines. But you could see, if it passes, you could see people coming into Oregon with out-of-state licenses and they practice under the license from that state. So if they get in trouble here, I send them back to their home state. I don't have jurisdiction over them because they're not licensed here. So as an investigator. So does that answer your question? Okay. Okay, well, who was in the back? You? We'll go, you next. Yeah.
Whatever legislation passes will kind of provide like
For all the compact states, sorry, the question was, thank you. If somebody goes, if we're become a compact state and someone goes to practice in another state, their rules apply locally. Is that what you're asking?
Yeah,
Yes, there is. If you guys want to Google it later, there is a national EMS compact. You can go to their website and read all of the information about it. So if you have to pass legislation in your state to be part of a compact, and when you do, you abide by all the compact rules. So we have to kind of abide by what the compact says. So when you go to every state, it should be the same. Now, scope of practice and things like that will be dependent on where you are deployed or working in that state and what that state says. Well, no, you're going to work under your scope from Oregon, or you're going to work under your scope from Kansas, or I can't remember who's in the compact right now. Does that answer your question? Okay, your question. Yeah. That's a good question. So the question was, I got my Oregon license, my EMT license mid-cycle last year. How do I do the CE going forward? Most people who get their initial license in Oregon will have a national registry certificate for those first 2 years because we require it for initial licensure. So for you, you should have a national registry certificate. When you renew in Oregon, if you have a current national registry, you do not have to do separate CE for Oregon because national registry for EMT requires 40 hours. That fulfills the Oregon 24-hour requirement. You do not have to keep your national registry certificate to practice in Oregon. You just have to have it for initial licensure. If you let your national go, totally up to you, then you apply it to Appendix 1 and do the 24 hours for Oregon. So for you, you should be fine. You shouldn't have to do any CE for this renewal cycle. You still have to renew though. Cool? Yeah. Good question. So if we get adopted into the compact or it passes, how does that deal with medical direction? Again, it depends on which state you're going to. We've never been part of a compact, so we're all going to learn in all of this. Go to the compact website. They have some good FAQs. But again, it depends on the state you're going to. And for Oregon, we'll decide, are you going to work under Oregon medical director or home state medical director if they come here? So one of those things we have to kind of hash out in the rules. Good question.
In the legislation and stuff that's coming up, are they going to acknowledge our rural volunteer agencies? I'm an intermediate. I have a ton of EMRs on an agency, but if I'm on an ambulance with a driver and an EMR, I cannot function as an intermediate. Are they going to acknowledge at any point in time without having to jump through all the hoops of the exemption? That is ridiculous.
Are you talking?
I can have an EMT driving the ambulance and I can be an intermediate in the back.
Yep.
But I can't be an intermediate at the back if my driver is just licensed, it's just a driver, and I have an EMR sitting next to me. No, what I've been told is I cannot function, I have to be BLS only when I do not have another EMT in the ambulance.
So I'm going to repeat the question. The question was for you're transporting ambulance service?
Yes.
So the question was, basically, if an intermediate is transporting a patient, are they restricted to a different, like a BLS scope if they only have an EMR or a qualified driver driving the ambulance? I'm going to talk to you afterwards because it depends on your agency. Veronica does all of the service licensing. You can apply for the exception to be able to transport and bill, but it's going to be kind of dependent on the agency and what your medical director wants too. So we'll want to make sure I have the right situation with you. You should be able to use your scope.
With the exception, I understand. What I'm saying is, are they going to come a point in time where our small rural agencies are struggling like crazy?
Sure.
They're buying EMTs, EMRs, and I'm not trying to get around it. Like,
Yeah.
Who else is in the ambulance doesn't necessarily affect my ability to start my.
And those are the questions that you should join and bring to our rules advisory committee meetings, because that's where you guys have a voice. All the rules in those 250s and 255s that pertain to licensed services of what staffing they need to have, you can directly give that input, because that's how it changes. Is when you guys come and you're like, this is a problem for us, your rules are old or antiquated or they're not working for today's EMS, bring that. That's what we need. So yeah. Sorry, taking all of the mic time.
We knew you were going to be the one who was answering.
Sorry.
That's why I brought her.
Go ahead. So the comment was, you're at your agency as well, you have intermediates and you can run at your full scope with a driver, probably with that exception. So as the current rules are written, you have to get the exception to do that. Doesn't mean we can't change it in the future, but you should be able to use your full scope if you have a driver. Okay. Oh, yes, here.
Fingerprints, back to fingerprints. Is there an exception for college students that want to still practice in Oregon but are going out of state? Is there an exception to the fingerprint rule? If they're going to college, our college students want to still practice in Oregon?
That's a whole question. Like,
Yeah.
Doesn't mention Prince though.
But that's when she asked her this time.
So I'm going to answer the question. I think the person that typed in the chat, is there an exception for college students that still want to practice in Oregon? We're thinking that applies to fingerprints because it came in then, but please clarify. There are no exceptions right now for fingerprinting for initial licensure. I know there's a $56 fee that goes to the Oregon State Police and the FBI that does not come to us. We do a national background check for all initial licensees. Again, as Stella stated, during renewal, if you live out of state, don't have an Oregon driver's license or have traveled more than 60 consecutive days, you have to do prints again. We do a statewide OSP background check on everybody, every renewal. If you don't live here, I can't do that. Hence why we ask you to get prints. So that's for the security and safety of the public in our system. But there are no exceptions, except for in the case of military, when you can upload your DD-214, okay? And we can't share prints. Everybody was asked, I got printed from my fire department. Can you just call them and get it? Federally, that's a federal law. We can't share fingerprint records, and that's for your protection. Huh? Anybody. Nobody should be sharing your fingerprint records. I can't print them. I can't put them in an email and say, this person applied, and ask my coworkers, this person applied and this is their arrest record. It's very secure. We go through training every 2 years. You guys know, CJIS clearance.
If it makes anybody feel any better, like we have to get we work for the state police. So
Yeah, so it's not personal, okay? Okay.
How much longer will Oregon have the EMT intermediate?
It's not on the chopping block, so no, it's not going anywhere. I know that kind of comes up every now and then of like, oh, we're gonna go away from it's not happening. I would know. So no, you guys get to keep your intermediates. We're not taking it away. Yeah, next question.
Your director, several occasions have an EMT. We talked about other states. So I think that's where that question comes from. So systematic support for that, and I mean, getting rid of the APIs, I appreciate you guys for that. It's really regressive to really. And so, just as a point of feedback, people need to have very important.
Yeah, so online there, a comment was made just that how important and pivotal that intermediate is to the rural and frontier communities in Oregon. I completely agree. You guys saw the numbers. Most of our college programs now will host an AEMT course and then piggyback the intermediate on like for 2 weeks afterwards. So most people go straight that path all the way to intermediate. Oregon's unique. We've always been pretty progressive. We have a very expansive scope. If you compare it to nationally, paramedics being able to pretty much do anything the medical director wants them to. From a drug standpoint and RSI. A lot of states don't RSI, you guys. So if you go to national conferences and talk, people are usually like, whoa, you guys get to do that in Oregon? There's no plans to get rid of the intermediate. I hear you. It's vital for those rural communities, especially from a cardiac standpoint, because that's basically what the intermediate is, being able to treat cardiac arrest. And you guys saw the numbers. I think we have 240 AEMTs, and most of them are intermediates. So again, you guys get emails, whether they go to your junk or whatever from the e-license system. Whenever we make a rule change, flag those emails and read through them, glance through them. If there was ever a hint of us changing the license levels, you guys are going to hear about it. You're going to know about it through that process, and you can comment. But again, right now, despite what people have said in the past, if they like it or don't like it from a policy standpoint, it's not going anywhere. Okay. Yeah.
Last year,
It was our office, but yeah.
but so there was reports of the intermediate scope of practice being expanded, and it was like adding benzos and mostly drugs. Has that happened?
Okay, so the question in the room was, last year there was some conversation about the scope of practice changing and expanding for intermediates to include benzos. Fun fact, that's the Oregon Medical Board. The Oregon Medical Board, because as licensed professionals, as licensed EMTs, we practice under a physician, okay? That's why paramedics, EMTs, advanced are only allowed to practice with an agency with established protocols, okay? That's an Oregon Medical Board question because they've developed the scope of practice. And they have a quarterly meeting as well. They have the Oregon Medical Board has a quarterly meeting where they discuss this very thing. It's open to the public. You can go to it and you can send them emails and requests for scope changes. Not always going to get adopted because we have to also factor in the education that's required, right? That initial education, it just kind of tacks that on, and the scope creep is something we try to be mindful of. Okay, so good question. That's an Oregon Medical Board question. It's not in there now, but you could definitely ask them.
General. Oh, actually, this is a really good one. How would the compact work with intermediates since we're not national levels? It's not a national level.
Good question. I'll be honest.
Website.
I have no idea. I have no idea. If it passes and we go through the compact, our intermediates, I'm going to have to find that out because I don't know. You might have to, for anybody that maybe would be practicing under an AEMT at that point, if you did travel, but I don't know. I'd have to talk to the compact. It would, but again, they only recognize the national registry levels. So I don't know if they would let people, if they have an intermediate license in Oregon, move at all, or if they would move them down to an AEMT level, I don't know. Because again, for our intermediates, most of them, when we transitioned 15, 20 years ago, everybody had to get their AEMT and then it went to intermediate. But before it was just, I got my EMTB and I went to intermediate. There was no AEMT, right? So I never had an AEMT license. I have a paramedic license now. But so I would probably fall in that weird range if I never had an AEMT license. Sounds like you're getting ready to leave. It sounds like you're getting ready to leave. You're like, just kidding. Yeah. We'd have to talk with the National Registry. The question on in the room was for people who are an intermediate who never held an AEMT license, what does that work and what does that look like for the compact? So we'd have to figure that out. Again, we're kind of a long ways from that. If the bill passes, and then we have, was there a timeline for the new mod 2? An implementation date?
No.
There's no date on there?
It would go into, if it passes and signed, it would be.
The question,
120 days, or January 1st next year.
okay, so the question was for the new EMS mod, if the compact went through and passed, with all these bills, there's an implementation date, which they usually date it out because we have to have time to do all the work we need to do to be able to do the work. So usually it's like a January 1st, 2026 or January 1st, 2027. We'll have to look at the bill. That gives us that time to write the rules because this is just the statute. We have to go and build all the rules. So that's where you guys could be on a rules advisory committee and weigh in to what it actually says, the nitty gritty.
And I kind of answered it, but I just want to make sure since we're doing hybrid. Is there any talk of expanding the AEMT scope to help providers better services in rural areas? Sorry, I was reading that verbatim.
So again, good question. So if you guys are familiar, those are national levels. There's a national EMS scope of practice and a national EMS education model. So traditionally, no, if it's not outlined in that national model, because your community colleges teach that course, there aren't usually a lot of things added to the scope. That's why for Oregon, we have the intermediate course. So if you wanted to go, you could go to the intermediate course, but we try to confine and stay within those confines. So we don't have AEMTs here that are innovating where most of the other country, they're not innovating. That's not within their scope, right? So we try to stay within those national guidelines.
Opportunities for one more question. If not, I'm going to ask.
I know, anything, you guys, come on. What? Oh, gosh, yeah. Oh, okay. How much time do we have? So the question in the room was, No. The Blue Mountain staff are right over here. They can talk about it. The question in the room was, can we talk about the initial education testing changes? In a very loving way, that's a National Registry thing. It's a very loving way. That's my PC answer. Again, we rely on the national testing model for initial licensure. We are a regulatory body. We are not the educators. So we identify what we need you guys to come to us with to be able to get licensure. Just like nursings need to have an NCLEX. So National Registry has changed their process, and we are trying to change with them because they were like, your guidelines, your skills sheets that everybody's had forever, they're like, we're not using those anymore. States, figure it out. So we're like, cool. So we're working with community colleges very closely, coming up with this competency-based assessment. So it's good. We're moving EMS forward. That's how the testing should be. It shouldn't be a one-day skills assessment that we all sweated through. Everybody remembers, yeah. The comment in the room was, I had to sweat through it. So I hear you. I understand it can be better, but I'm with you. So it's National Registry. So we're changing it. Every state's going to be a little bit different, which is also kind of fun. But Oregon, Leslie Huntington is working with all the colleges and doing a great job. But it's still getting ironed out. So reentry for people is kind of challenging. We're looking at that because we don't have a psychomotor skills day. National Registry, I had a meeting with them last week. They're like, don't say psychomotor anymore. I'm like, everybody still uses the term EMT basic. So I'm still going to say psychomotor for a while. It takes a while for me to quit using the term, right? So, but yeah, so I don't want to dodge your question, but it was a National Registry change and we're trying to change with it in the best way we can. Okay. Okay. Sorry.
One more question and then we'll be done. And we are down. This actually, I'm just speaking into the microphone so that the people online know that they need to come next year in person. We are going to be down. Rebecca's going to be here for today to answer any other questions if you don't want to talk in front of the entire conference. But the final question, has there been any discussion long-term in order to expand the profession of bringing education requirements in line with other countries such as Canada, UK, Australia, and New Zealand, for example, have a 3 to 4 year university level education requirements for their providers, especially through the lens of expanding into community paramedicine, or what other discussions has taken place on moving the profession forward?
And I think we're at time, actually. Okay, I'm gonna try and make this quick, and let's get the person's name, and I can reach out to them too online. I think that's amazing. I think it would be amazing for EMS to move forward to a 4-year degree. They're doing it at OIT, OHSU. I think it's the best way to move a profession forward. Unfortunately, Oregon is one of the only states in the country that still has an associate's degree required to be a paramedic. So it's got to be a national conversation. If we're ever going to move into a 4-year degree, we need to get the country kind of on board with a 2-year degree. So there are people that are talking at a national level, trying to get that to happen. But with workforce crisis issues going on right now, adding more to it we're swimming upstream, unfortunately. So again, I don't have a say in it. I'm just the regulatory body. I have to be Switzerland. I have to not have an opinion. But yes, I would love to get EMS go in that direction. Unfortunately, it just might take a pause, especially like post-COVID. So thank you guys so much.